Ladies and gentlemen, welcome in once again to another wonderful, or possibly boring, lecture. This one's a double lecture, pediatric imaging followed immediately by geriatric imaging. And I know this is put together at last minute, but we had some scheduled changes for the Veterans Day holiday mistake that all of the faculty made. So I share that blame with Mr. Shepard. Amore Jenkins is innocent. She was using Mr. Shepard's schedule, so it was me and Mr. Shepard that messed that up. But anyway, here we are. So I'm going to give you a recorded lecture to listen to this weekend, or maybe Monday night as you get to it. We're going to be pressed for time on Monday, and so this is the only content you're going to have on pediatric and geriatric imaging. All right. So things to keep in mind for pediatric imaging is we want to shift our vocabulary, not just to lay people, but now we have to consider an audience that has a limited vocabulary. And so we really have to watch the words that we're using, and we got to make it fun if we can. And that's going to be a giant driver for getting to a completed exam is making it, at least for the younger pediatric crowd, making it into playtime, making it into a little use of imagination. We do have to dabble with some psychology. The emotional maturity of this age group is less developed than our adult patients, and so they can lose the balance of emotional stability all that much more fast. And that really is critical to keeping them bought into the process and keeping them participating in the process. Unfortunately, we do have to talk a little bit about child abuse signs. Just every radiographer should recognize the bucket handle fracture of the knee for shaken babies, and then various common visual or, well, they're not really. Yeah, they kind of are objective. I mean, you're witnessing different colors of bruises in different states of healing. And then perhaps a unreasonable number of scars, burns, scratches, cuts, more than what you would see with a typical child, and especially in the modern era where we don't let kids play with rusty nails anymore, and we helicopter parent, and the children don't get a chance to explore right to the edge of danger like we did with Generation X. And there's pros and cons to that. But immobilization, all the wonderful things you can do with sandbags and tape. And then we are going to touch on some unique pathologies. Most of those are going to be congenital defects, and a lot of those, thankfully, through the magic of laparoscopic surgery and ultrasound, we now have the tools capable such that some of those birth defects can actually be repaired in utero before the child is born. So let's get into it. All right, here are our objectives. We want to develop those communication skills for the various age groups. And so, yes, we are going to have some 2-year-olds where you're really communicating with a parent, 2-year-old unless you're communicating with a parent, and then roughly 3 to about 6 or 7, they're going to be the world's best journalists. They're just natural scientists in that age range. They're infinitely curious about everything. They just want to explore and figure out stuff and ask you questions, and they're really in, and they're also really into play and pretend and their imaginations and things like that. Just having fun and figuring things out. Okay. And then as we get later, somewhere between 8 and 12, they start turning into a teenager. Yes, some teenagers are being formed at 9 and 10, um, at least the attitude of a teenager. And that's good and bad. And you won't really see, you shouldn't see much attitude. It'll more be a shyness, an awkwardness, a really guarding their privacy type. I don't see a whole lot of disrespectfulness. Now I could be wrong. It's been 15 years since I x-rayed anybody, so it might be that you do start to see some sassy folks too. So proper immobilization techniques, yeah, like what I said just now. So common pathologies, and then unique procedures, and then I do want you to look at that handout that's in this folder, the sulcus sign. So when normally for pneumothorax for our adult patients, we have them upright, and so the air bubble manifests typically in the neighborhood of the apex of the lung. When you lay a patient down, the air bubble actually goes to the diaphragm, and it kind of looks like an extended, the sulcus sign or false foot sign kind of looks like a hypertrophic costophrenic angle. That's really free air between the costophrenic angle of the lung and the diaphragm. So better explained on that handout, so please take the time to glance at that. All right, so first and foremost, children are not small adults. It's a different mindset, a extremely different mindset. Priorities, even understanding what priorities are, any sense of responsibility, no. 0, 100% no. I mean, even some adult men are like that. Yes, ladies, will pause for about 5 seconds for you to stop laughing. Two main area of problems in radiographer confidence, and that's how do we communicate to young people? And it really is practice, and it really is, it's kind of assessment on the fly, and you've got to manage, the comfort level of the child. You don't want to intimidate. Taking a knee is very effective at reducing that intimidation. Okay, come down to their eye level. Every time I start recording, the phone starts ringing. God bless. Immobilization techniques. You got to be practiced in immobilization and do it. Be sure of yourself and do it in such a way that you're not hurting your patient. Now, for a fractured arm, you are going to be hurting then, right? The best is not necessarily to immobilize, but try to get cooperation and try not to move it as much, rather than sandbagging or taping that thing down. Okay. So you've got this psychological hurdle of the child is probably anxious and upset and fearful. Okay. Radiographers don't carry needles, and we don't stick people, but they don't know that. They see scrubs and they panic. Okay. They don't know that you don't have needles. Okay. They don't know that some of them, if it's their first x-ray and it's their first time taking, they might have had an x-ray as a baby, but they really don't remember that. If it's their first time having an x-ray and they're like 5, it's scary. That machine is scary. That's a big machine. Okay. And so a lot of things are intimidating in the hospital for the younger set. For your adolescents, it's either frustration, maybe a little bit of anxiety, annoyance, highly protective of privacy, and that manifests as shyness and awkwardness and things of that nature. Okay. Yeah. All right. So these are things that we have to adapt quite a bit from the way we normally do an adult patient. It's almost like you're x-raying a different species. That's how night and day different this is than x-raying adults. Okay. Atmosphere and environment, and this is like the physical environment. Between that and your playing into the imagination with your directions and making it into a playful activity or making it into an exploration activity, there is no harm in letting the child touch some of the buttons if they can reach. Maybe even put them up on a step stool. Okay, I don't care about the fall risk, right? I'm Gen X. They can scrape their knee and live. I stand as witness to that. They can scrape their knee more times than you can count. They can live, right? So put them up on a step stool, let them grab the button, let them move the x-ray tube, right? Show them that it's not scary. It's just a machine, okay? Atmosphere of patient care affects recovery rate. So if they think they're in a warm, friendly environment instead of a cold, sterile hospital, then they will adopt a better attitude, and they will actually recover from illness or injury faster if they think they're in a supportive and warm and playful and fun environment. Okay. So pediatric imaging centers and pediatric hospitals, they go overboard with, and rightfully so, with decorations and bright colors and fish tanks and aquariums. And there's a Vanderbilt on the second level right outside the cafeteria. They've got like a radio station / karaoke studio, and the kids that are well enough can come down and sing karaoke and schedule programs, and it's broadcast on Vanderbilt TV inside the hospital. So it's pretty cool. So it's kind of like being on American's Got Talent or whatever show. I don't watch those. I play video games. But it's kind of a fun activity. So distraction. Okay. Anxiety is eradicated when you distract yourself. Okay. When you distract your patient. Okay. So it's an effective management tool for self-regulation of anxiety. Just pick up a book and start reading. Okay. And then you're not, it's when your brain is doing nothing that it has the opportunity to worry and fret. So give your brain something to do. Okay. And the same thing applies for your child patients. Give them something to focus on other than their injury or their illness. Okay. Right. Approach is the other half of, so if atmosphere is recreating the hospital as a play place, approach is recreating the healthcare professional as a new friend, as a buddy, as a, someone that's going to help them out, and we're going to play pretend and take some pictures. Okay. Now, the approach varies regardless, or not regardless, according to age range. So imagination games and fun games don't work if the child doesn't speak. Okay, if they're nonverbal and they haven't acquired language yet. So like typically under 2, we do have some advanced children that are speaking at 18 months or even faster. So you really got to gauge it as to what you're getting out of the child. Okay. If you're only getting an expression of emotion, well then defer to the parents. Okay. And if you can get mom or dad alone and whisper to them, it's like, just buy in with me and, be convincing, because the child's going to be trying to read emotions off of you. So if you look nervous, the child's going to be nervous. And really, yeah, that's the best advice, is coach your parents into a proper emotional state, or into a proper, put on the game face, put on the smiley face, because so many times I have seen a pediatric patient that was just fine, and then they looked at mom, and mom has got this, she's about to break into tears at any minute. And it's like the child looks at mom and really takes it in. There's a pause, just like a 10-second pause looking at mom. And then the eyes squinch up and the mouth opens and they just start wailing. Yeah. So the child didn't know to be afraid until mom gave them the signs that this was, this is kind of tricky, and this is a situation. This is something that's it's stressing mom's emotions. So if mom and dad are cool-headed and it's going to be fine, it's going to be okay, well then, yeah, the child is going to, respond in kind. So if the child, usually it's somewhere around 5, even the 2, 3, and 4-year-olds, not quite yet, but those 5 and 6-year-olds, they're all about imagination. And so the approach is probably the hardest pediatric patient to x-ray is the 18-month to 2-month-old. The easiest pediatric patient to x-ray is the 6 or 7-year-old. And they just flip into curiosity and exploring. They're not intimidated anymore. They just really want to, hey, what's that? What's that? Why does that do that? Why are we doing this? And they just pelt you with questions. So it can be overwhelming if you're not prepared for it. So understand that there's a big gulf and a big transition in comprehension and comfortableness with the world that happens somewhere between 2 years of age and 5 years of age. So. Okay. Dealing with an agitated parent, yes, that is Gandhi, and yeah, if there was ever anyone keeping their cool, yes, his fellow citizens were being falsely imprisoned, brought up on just phony charges. If they spoke out against British occupation, they were arrested and brought up on some ridiculous charges, and then God knows what happened to them. People were getting beaten in public. Riots were met with extreme violence, all the way up to shooting people to make them disperse. It was just a wild time back then. So amazing that Gandhi could just, he said, you can beat me, you can whip me, you can hang me, and then you will have my dead corpse to deal with, but you will never have my compliance. And so kind of, we want to adopt that kind of attitude, but we want to remain steadfast in our patience, and we are in control of the way things that are going to go. We want to be firm but nice and sweet. Well, no, we have to do this. It's going to be okay though, And so we want to have not necessarily the defiance, but definitely the steadfastness of, no, this is all right. This is not a big deal. We're just going to take some pictures, and constantly, reaffirming our stance that there's nothing to get upset about. Okay? Now, you will have to abandon this for the 3-year-old that just starts throwing in the temper tantrum. Okay? But hold out as long as you can. please hold out as long as you can, because sometimes in the final moments, like, okay, and then they stop. It's rare, but they do. Okay. So fear is a cause of agitation. The parents broadcasting fear, the child will mimic. The child will read mom and dad for cues as to how am I supposed to respond. Okay. And so you stay calm, and then maybe mom and dad stays calm. Mom and dad are calm, then child is calm. For the most part. Some of them just no. Okay. Listen without concern and interruption. That is very difficult. It is very hard for the modern technologists to exercise patience because we have exam turnaround times in the back of our head that we are fretting about. Okay? Forget about the exam turnaround times. You tell your manager I said so. It is more important that we do not psychologically scar our kids, these children, these patients, because we need to meet some kind of performance metric. Okay? These are human beings. They are not emotionally mature. We need to exercise some grace and some patience. Okay? You do have the power to set the mood. All right, parent participation. All right, so you also have to be assessing mom and dad and whether they're going to be a helper or a hindrance. Okay? I have totally kicked parents out of the room because I thought that they were just adding spark and tinder to the child's emotional state, right? Or dousing. If the child was the spark, they're adding the gasoline. Okay? And so, it's now if you get started along one path, right, you kind of have to stick to your guns. But if you can assess it early enough, you can say, it might be better if you wait outside here, and then we can perform this more effectively. Okay? If it looks like the child is in a full temper tantrum and is not even listening to the parents, it's probably separation is probably the best strategy, actually. Okay. There will be several staff radiographers that disagree with me on that point. It's subjective personal preference for each radiographer. I understand that. But it is an available tool. Okay? Your level of comfort and your staff technologist level of comfort with that tool, yeah, that's something that you're going to have a heads up on with your staff technologist before you even get started. Okay. Parents can assist with the immobilization. All right. Give them very specific instructions. Place their hands, especially if they have their hands in the light. Try to reposition their hands to outside the light. Okay. Parents witnessing the procedure cannot doubt your professional conduct. Okay. They saw what you did. All right. You shouldn't be anywhere near where they're thinking like, oh, this isn't what's supposed to happen. Okay. They should be reassured by your instructions and your demeanor and the way that you're managing the situation. Okay. Just a second here. All right, sorry about that. Got a text message. I didn't know who it was from. Approaching the child, parent and patient with a warm smile. So you are greeting the group first, right? But then you're assessing if it is appropriate to address the child individually. Then make sure that you change your posture, take a knee, and then start speaking. Okay. You do want to still confirm identity. You can figure out, and again, probably closer to 8 years old and higher, would you want to ask the patient about their name and date of birth? You probably get away with deferring to the parent for that question. For quite a bit older, all the way up to, I would say all the way up to 8 years old is fine. Okay. Tell the child what you're going to do, right? And occasionally glance up at mom and dad, make sure that they're tracking, they're understanding, so on and so forth. And then remember to stop and say, does anyone have any questions? Not just the child, but the parents do. Do any of you have any questions? So, but then follow that up with specifically to the child. Do you have any questions for me? Okay. This is actually key with autistic children. My son, when the teacher would address the classroom, she would say, some of you are blah, 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 blah. Well, John was totally in that group. But because she didn't say, and John, you, blah, 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 she just said some kids. She wasn't talking about me. She was talking about some kids. Wasn't me. So there's a whole lot of that with, when you're addressing a group, the individual autistic child thinks, well, that doesn't apply to me, and just sorts themselves out of that group. And you didn't intend for them to do that, but yeah, that was a big communication thing with my son all through school, was he never thought that a teacher addressing the entire class was specifically referring to any of his behaviors. Because if it was his behaviors, she would talk to him personally. So, okay. Approaching the child, and I'm so glad I left this in here just for y'all. I don't know if I shared this with you guys or not already. I might have, but I'm gonna anyway. So Adventure Time, right? And the reason that I left this in here is because you guys are actually the Adventure Time kids. It's been about 15 years. What? Oh my God, so old. So I made this when I started. I included Adventure Time as like one of my first lectures on pediatrics and geriatrics. And so that was about 12 and a half years ago. And so my target audience that I was thinking of was you and your younger siblings. Every time. Hang on just a second. Sorry. Okay. And then, of course, LeBron James, very popular even to this day with some of the younger folks. But you might want to switch that up to Steph Curry now. And yeah, I apologize. That's the only two I know, right? I know now. I can name 6 or 7 from Magic Johnson, Larry Bird, Michael Jordan, Hakeem Olajuwon, Patrick Ewing. You see, so I know quite a few more older NBA players from the 80s and 90s. LeBron, Kobe Bryant, rest in peace. Allen Iverson, and Steph Curry. Those are the only ones I know from the modern era. So, yeah, so sorry. The NBA for me died with Jordan. So, all right. So, infant to 6 months. What do they really need? Well, are they crawling? Maybe, maybe not. The majority are not. Okay, so they're just that. Now they have figured out how to hold their head up while laying prone, clearly. Okay, but some of them might be laying on their back, not figuring out the prone, belly surfer pose. Okay, but we are starting to see development of head control trunk control, that kind of stuff. And so it really is it's a spectrum of ability. Okay. But really their focus is, are they warm? Do they feel secure? Right? Is mom close by? Right? Sorry, dad. And is their belly full or is their belly empty? Right? And then the formula fed babies, are they constipated or are they not? Because formula is notorious for constipating babies. So yes, constipated at this age means cranky baby. So they are just miserable because the constipation will trigger gas and bloating, and then their tummy hurts. So that's just a side effect of formula feeding. So yeah, communication directly with them, no. So you are explaining the exam to the parent, right? You don't have to explain the exam to this age range, okay? You are going to basically put hands on them with mom and dad's permission. Mom and dad is going to help out, and you're basically just going to hold them in the position you need and line up the picture, okay? Now, most of the time we don't do upright chest x-rays on this group because that's not their natural posture. So we would do a supine chest, right? Unless specifically ordered. And then we'll use a pegostat. What? Yeah, a pegostat. Okay. Some technologists will refuse to use the pegostat. Okay. 6 months to 2 years, they really get that tether bonding. I don't know how many kids that I had to pry off of mom's lower leg, but it was more than I can count. Okay. Pain and the exacerbation of pain, right? Remember, it's pain experienced with very little emotional maturity. So every pain, think about their frame of reference. Every pain they experience is the worst pain they've ever experienced. Okay. They don't like to be separated from mom, so not an effective strategy. Now, but if they're in full-blown temper tantrum, you're at a point where the cooperation of the child is at zero, null, and you can't make it any worse. Okay? And so it might be easier, especially if mom and dad are hesitant to help out and they're fearful and they're kind of non-committal. Might be easier to kick them out of the room and just get things done. Okay? The 2-year-old to 3-year-old, that is the wrestling match. Okay, 6 months, not so much. Anywhere between 18 months and 3 years old, yeah, wrestling match all the way. Okay, hopefully you have a parent that's cooperative. The first time mom, it's a crapshoot. It's 50-50. Odds are not good. Okay, but mom who's on child number 3, oh yeah, she's like, let me help you hold him down. Right? She's going to jump right in. Okay. 2 to 4, curious. I would say all the way up into 6 and 7. Very curious. Okay. Wants to play games. Wants to play pretend. Okay. Very easily distractible. You can tell them a story. You can pretend that we're taking pictures. Right. Now you can do that but they'll more believe that it's actually just pictures, not x-rays. So they might not know what bones are, so don't say pictures of bones. Save that for the 5 and 6 years old. Okay, that'll really drive their curiosity and their exploration drive, which is just in overdrive anyway. Okay. All right. Maturity shifts into explorer. Now you might have some 5-year-olds that are not quite in explorer mode yet. They might be extra anxious and fearful, especially if, they've been spoiled and they've been If they've been taught that throwing a fit and losing control of their emotions gets them what they want, well, that delays their explorer mode and their curiosity mode. Okay. If, however, they've been parented more appropriately, right, then they have, just the start of emotional maturity where they can say, cool. Now, if the pain is severe enough, like a fracture, yeah, they're not going to be explorers. They just aren't. So, really depends on the details of the situation you're dealing with. Okay. 6 to 8 years old, there is no easier pediatric patient than a 6 to 8 year old. Okay, they think it's cool. They think your job is cool. They want to do your job when they grow up. They want to see the pictures. Yes, let them back there and see the pictures. You still can't tell them anything, but you can show them the parts of the bones and such. Okay. Try not to point out the fracture if you can help it. Okay. Preteens and adolescents able to understand. I did have a picture of the Twilight trio, but I might have nuked that. It might be on the next slide. Might have nuked that. But teenagers are into the latest whatever. Okay. And so pop culture trends, so long as they're appropriate, PG and G, right? Getting harder and harder to find stuff like that. But, the latest movies that are out, I think the Marvel Cinematic Universe is still a safe zone. Nothing too risque or controversial coming out of Marvel Cinematic Universe. Star Wars is a little dated. They killed that franchise, didn't they? But yeah, ages and the latest video games, you might see them, like Battlefield or Fortnite or whatever. So Roblox, I guess, is big. I have no idea. I've never seen Roblox, but I hear Roblox is big. So, all right. Your special needs patients. This slide near and dear to my heart because of my son. You can please communicate with the child as if they understand. Okay. My son has locked-in syndrome. He is nonverbal. Okay, doesn't have a vocabulary. He is able to emote very, very well, and he's able to make hand signs very, very well to indicate what needs attention. Okay, he pats his diaper when he needs changing. He turns light switches on and off. He opens and closes doors by himself now. He pats the dinner table when he wants to eat. Okay, he comes over and bugs us when he wants something. He brings us the Bluetooth speaker when he wants the song changed. Okay, does it sound like I'm kind of annoyed and irritated? Yeah, I mean, the kid's got the right life of Riley, and I just wait on him hand and foot, and yeah. So sometimes my patience wears a little thin, and it's just me being human and being less than perfect. I need to remember, who he is and what challenges he's facing. But yeah, so even children with disability, they still want some autonomy, especially if they have limited language, right? They still want autonomy. They still want to be talked. They want to be addressed and treated like an individual, not like a subject, so to speak. And so and that's everybody really. It's part of being human. You want to be respected, and the first step in that is acknowledge me as an individual. Acknowledge me. I'm not a possession of my parents. I am a person, right? Even if they're nonverbal, they can't talk to you, they might fully understand everything that you're saying. So be mindful of that. Psychological considerations. Okay, calm tone and manner. Right. Don't abandon that prematurely. Stay the course. Okay. It's going to be okay. Don't get freaked out. You're the last one that needs to be freaked out. Because if you freak out, it will trigger the chain reaction. The parents will freak out, and then the kid will freak out. So you can't freak out. Now, the parents might undermine and freak out. You can't help that. Okay? All you can do is remind them that, hey, let's, this is a team effort type thing, Um, the parents might also lack emotional maturity in some cases. Okay? And so they might be, usually first time mom, it manifests as anxiety and fear and worry. Um, Sometimes with more experienced parents, they just angry. Okay. Communicate. Keep your tone calm. Tell them what we're about to do. Okay. Tell them if we need 2 views, we're going to take at least 2 pictures. We might have to take more. Okay. You never want to say 2 pictures and we're out of here. Don't do that. You're setting them up for expectations that are unreasonable. Okay. We're going to take at least 2 pictures. We may have to take more. Okay. After the procedure, okay, it really is, you really have to have an eye on because I have had some where it's like, if I see the orthopedic surgeon outside, right, I'll even say, excuse myself, and I'll go out and address him. I'm like, you want to call somebody and get a stretcher and you can go right from here? And it'd be like, yeah, where's the phone? And then you just take them over to the department telephone in the control area, right, or wherever it is in the main congregation area, and let him use the phone, right? And that gets him doing a task that expedites, and you made a doctor help you and become your assistant. So that's kind of cool. Okay. But yeah, understand that sometimes it's X-ray, and then we're transporting surgery. Okay. Now some of the surgeons are like, nah, we'll send for them, that kind of thing. Okay. You just have to have the lowdown of what's happening next, so you can tell the parents. Okay. Now for more routine stuff, and stuff where the orthopod is not in the building, like overnights, right? You have to remind them that it's going to take a little bit of time. Okay. And so a lot of times what I do is I say there's probably other tests that need to be run, right, before they commit to any particular game plan. All right. And they're probably going to want to bring in, in the case of a fracture, I'll just say, that's not diagnosing. That's just, they're probably going to want to bring in an orthopedic doctor for a consultation. Okay. I might do that for an aggressive sprain too. You haven't diagnosed. You're just giving a heads up as to what might happen. Okay. And so, but you should always communicate that there potentially is going to be a little bit of wait until we get to treatment. All right. All right. So your ER patients are definitely the most challenging. Your inpatients probably about equivalently challenging, because the inpatients, the reason we've made the pediatric patient inpatient is because their condition is serious. It is a positive diagnosis, and we need to schedule them for some kind of treatment, and it might not be immediate. It might be next day. So, now typically the advantage of inpatients is they've been in the building long enough to be juiced with pain meds, and so slightly easier. Okay, pain meds make the difference. Oh my God, they make the difference. Okay, it is so much easier for a patient to hold still when they don't feel any pain. Okay, even with the arm should be set, that is, set and braced before they go up to the floor at the bare minimum. But like a fracture that's fresh and hasn't been fixated and braced, pain meds make the difference as to how good that exam's going to go. Okay, your outpatient pediatrics are going to be among the easiest patients in the pediatric age range. Physical considerations. Okay, so especially with the inpatients, most of the policies now are nurse comes down, always. Okay, that is a vast improvement from when I started this career. Okay, the nurse or the parent knows the limitations of the child, and so if, let's say, they have contracted legs, well, those legs we're not straightening those out. Okay, we're going to have to figure out a way to get the images without straightening the legs. Okay, can they lay down? Can they stand up? Okay, we only have so many options. We can either do it laying down or standing up. So, yeah. Okay. Inpatients, they're monitoring input and output. Okay, I guarantee you, if the patient's wearing a diaper, input output is being monitored, and so the diapers have to be weighed. Okay, they should. If you don't have a scale in the X-ray department, there ought to be a scale in the emergency department. Ought to be. Okay. You can also wrap up the soiled diaper. Okay. I wouldn't put it in a pillowcase, but I would put it like at the foot of the bed. Okay. And make the transporter aware or the nurse aware that soiled diaper is being included in the transport back to the room, so the nurse can take it and weigh it before they dispose of it. Okay. If you can get a weight yourself, document the weight on the electronic medical record, right, and call the nurse and report to them that you documented the weight of a soiled diaper. Okay. Special concerns. A lot of these are congenital defects, congenital birth defects. Okay. Premature infant, not really. I mean, it's not a specific pathology, but it is a special case scenario. They don't have the baby fat. That doesn't happen until month 8 and 9, right? And so before any preterm child born before month 8 is not going to have adipose tissue for insulation, and so they're going to struggle with hypothermia and maintaining body temperature. Okay, so just like the French fries at McDonald's, you got to keep them under the heat lamps, keep them warm. Okay, that is an issue when we go to the NICU. That's also an issue when we bring them down to the fluoroscopy room, because we don't have a competent, we got to put the floor tube over top of them, so the heat lamps can't be over top of them. So they are going to get cold if we bring them down for fluoroscopy. Okay. Myelomeningeal seal goes hand in hand with spina bifida. It is a herniation of the meninges, and so the spinal cord is open, and cerebral spinal fluid is seeping and weeping out of their back. Okay. Spina bifida and myelomeningeal seal can be mitigated in utero. They can sew everything shut. They can't fix the paralysis. That damage is already done. So lower extremity paralysis can't be fixed, but they can close the hernia. Okay? Omephyseal and gastroschisis. Omephyseal is other intestinal organs. Gastroschisis is the stomach in particular. And the problem is they are forming those organs outside of their peritoneal cavity and outside of their anterior abdominal wall. Okay? Epiglottitis is a serious condition that's brought about by RSV and other causes of the common cold, and it just, for whatever reason, it decides to inflame the lower pharynx and the epiglottis, and it could cause it to swell shut and close the airway. Okay, and so it's a very serious condition, and it is an emergent condition. Okay? Osteogenesis imperfecta, made let's say popular, but made well known by Samuel L. Jackson's character, Mr. Glass. That is an excellent trilogy. If you haven't seen that trilogy, I think Glass is the third one. Kevin Wendell Crumb, Split, and then it's called Invincible or something. I don't know. Bruce Willis as the non-injurable superhero in the raincoat is the first one to kick the movie off. So kick that trilogy off. It's a fantastic trilogy. It's a fantastic plot line. M. Night Shyamalan did so wonderful with that series. And oh my God, a Split with who's the guy who plays young Professor X? I forget his name, the actor's name. But he does such an amazing job. He is such an amazing actor. Oh my God. So good in that movie. Okay. Premature infant. Yeah, already covered this stuff. Hypothermia all day. Okay. When we're doing portables, let's work quick as we can so we can get the heat lamps back over them as fast as possible. If we're bringing them down to the fluoroscopy suite, also let's move as fast as possible so they can get back to a warm environment as quickly as possible. Okay. If the baby is in an isolette, that's a bassinet with a cover on it, it might be that the nurse places the cassette for you. It might be that it has a crawl space under it where you can place the image receptor or cassette, and therefore you don't have to put the cassette inside the bassinet with the infant, and that just reduces the possibility of infection. Myelomeningeal seal, yeah, I talked about this already. It goes hand in hand with spina bifida. It is cystic protrusion of the meninges, spinal cord tissue, and fluid. So basically it's a hernia of the central nervous systems. The meninges are not sealed and closed like they ought to be. Okay. This does now between the two. There is paralysis and hydrocephalus, which is wild because the cerebral spinal fluid is weeping out. I guess sometimes it gets stenosed and trapped depending upon the degree of spina bifida. Okay. If the patient is, now remember I said advances in modern medicine, we can sew the hernia shut in utero. Okay. If you have an open myelomeningeal seal in an untreated case, you do need to switch to prone positioning. Okay, so don't lay the patient on their back, lay them on their stomach for the x-rays. All right, already talked about these, so real quick. This also can be repaired in utero with the advances in laparoscopic surgery and ultrasound. And so we don't often see this anymore. Okay, The nurse should be coming down and should have an irrigation set. That is a turkey baster and a basin full of lactated ringers or whatever it is they're going to be using to irrigate. Okay, and so if they don't come down prepared, well, that's on them. Okay. If you're doing it portably, understand that you're going to be working around the nurse that is constantly going to be keeping the membrane of the stomach and possibly other organs moist and lubricated and preventing them from drying out by constantly basting them with lactated ringers. So it's just the nature of it. Okay. Again, this is rare. We don't have these type of patients anymore because most of the parents opt for laparoscopic in utero repair of this condition. Okay. Epiglottitis, we can see it here all the way at the bottom, right where we lose density with the shoulder. You can see that the airway is tapering into a sharp point right there. So that's complete occlusion of the airway. The stenosis it's basically pinched off right there where the epiglottis is. Okay, and so the airway is effectively blocked, and it doesn't matter how much the child thrashes or struggles or chokes or coughs, the epiglottis is swollen shut. Okay, now I said RSV, influenza is more common causing this than RSV. 3 to 6 years old is when it most likely occurs, but it can occur in older and younger patients. So it's a risk all through childhood. I would say probably up to age 8, 9. It's a pretty big risk. Okay. So we're going to be doing this study portably. We're probably going to get a lateral soft tissue neck like you see here. And we're going to get the heck out of the way as fast as we can so that the interventional team can establish an airway, whether that be through a intubation if they can get around the swollen epiglottis. It might be, steroid injection through the thyroid, all the way, a deep needle all the way through the thyroid. It's a little tricky. The carotid and jugular, they're a little bit more lateral, but they are in the neighborhood. So, and also we don't want to puncture the trachea. We want to hit the tissue of the tongue muscle and around the epiglottis, but we don't want to advance the needle into the trachea because that creates a hole or perforation in the trachea, and that just exacerbates your problems. So, brittle bone disease, again, Samuel, I really need to add Mr. Glass's picture to this slide, although he is not a pediatric patient. So the reason this is just sad, the reason osteogenesis imperfecta is in the pediatric chapter is because these folks do not have a long lifespan. It is very rare for them to become teenagers, and adults are extremely rare with osteogenesis imperfecta. It is that debilitating a disease. The spine literally, or not the spine, but the entire skeleton literally crumbles into powder at just the slightest pressure. And it is a genetic deformity of how the bone matrix is built, and it lacks rigidity for whatever reason. Okay, it's a variation of bone and a variation of how the bone is being built, and it's got a genetic source to it. So it's tragic. So if you have a patient with osteogenesis imperfecta, you are going to be careful, and you're going to move slow, and you still might fracture them. Okay, get a veteran tech with you. Always buddy up, not 2 novice techs. Get somebody with gray hair. Get one of the older techs to help you out with this one. Slow and careful, and understand that you still might break a bone in the process of x-raying a broken bone. So just do the best you can. Okay. Child abuse, there's those bucket handle fractures that I spoke of. So this is, I think these are knee joints. There's also quite a bit of edema and bilateral dislocation. That is an unusually large joint space for a baby's knee. That is 2 inches of space between the femur and the tibia. That is, and that gray blob, that's blood. That's hematoma. Okay. And those bucket handle fractures on the tibial plateau, you see those crescent white handle shapes. Those only form one way, shaking a baby. That's the only way you get that type of fracture. Okay. And so this is a dead ringer. Now, most of the suspected child abuse patients, you are going to x-ray. They already know. They already have separated them from the parents. There's already a social worker assigned. They're already in a protective ward of the state by the time we get to x-ray them. Okay. It is extremely rare that the radiographer is the one that makes the discovery. Nonetheless, you should be on the lookout for these type of fractures, especially if it's altogether missing from the history. Okay. You should also look for the clinical signs of bruises in various states of healing and look for different colors. So fresh bruises are purple, old bruises are green, right? And then brown, or no, it goes purple, brown, then green. Okay. And so if you have some green ones and some brown ones and some purple ones, well, that means that not only is the child getting contusions, but they're getting them over the course of several weeks and months. Okay. And so it's repeated injury, right? And then how many times is a child going to burn their arms? Okay. In the exact silhouette or shape of a cigarette. Or the, thank God we've gotten rid of those car cigarette lighters, those things. They were just too great a temptation for some folks. So, but one burned, that's an accident, right? 6 burns in various locations, that is not accidental. Okay. Same with cuts. Cuts and scrapes on the shins, yeah, that was me. That was me until I was like 14. Come on, right? But cuts and scrapes on the back, on the arms, and on the shins, and on the thighs, like all over the body, and an unusual number of them, no, that's abuse. Yeah, that's abuse. So just the quantity, right? The range, right? Cuts and scrapes below the knee or at the knee, that's not unusual. Okay. Cuts and scrapes like under the arm, across the belly, right? What are they doing? Are they doing Marine Corps boot camp? Are they crawling on their belly under an 8-inch clearance of barbed wire? Come on. Okay. So, protection of the child. We protect from injury, right? Now, this is outside of child abuse. This is just every time we do an exam, right? We're safety conscious. We understand the child is injured. We don't want to exacerbate the injury. We want to get x-rays, but we don't want to manipulate excessively. If the child's being immobilized and the emergency room has decided, or the EMT and paramedics have decided that the child needs immobilization, it's not up to us to decide that we can take that immobilizer off. We need permission. Okay. We will employ other immobilization tools, sandbags, positioning sponges, tape, so on and so forth. Rolled up blankets, rolled up sheets. Okay. The lap shield for your newborn infants. A 5-pound half shield is an effective immobilizer, especially with mom or dad's hand over top of their ASIS, like pinning the ASIS to the table. Okay. We're going to use shielding when appropriate. This is about the boundary right there. That's still diagnostic. Okay. And so a contact shield for males. Okay. You won't be able to shield all your female patients. You just won't. Okay. We do have to see the bony pelvis. Okay. If the child can understand hold still, well then, for God's sake, just tell them to hold still. If you have cooperative patients, that's what we do with adults. Okay, now hold still. We got to make a nice clear picture. All right. So don't forget the communication. That's clear communication. Sometimes that's all you need. Okay. Pegostat, very controversial, right? A lot of techs refuse to use this, right? I think all techs recognize that it's a baby torturing device. Some of us are more comfortable torturing babies than others. I'm in the later group. I have no problem putting a patient into a pegostat, okay? Because I know I'm not hurting them, okay? Unless I accidentally pinch them with a polymer plastic, but I do my best to try not to do that, and if I see that I'm doing that, I try to correct it, okay? The advantages of the pegostat is that when you're all by yourself on third shift, it's an extra set of arms. It's an extra patient holder, okay? And so it's a helper. And it's going to get the patient into the exact correct position. We don't have to worry about them tossing and slinging throwing their weight into their shoulders just as you're hitting the exposure and wrestling themselves out of mom's grip and then jumping down and running across the room, and then chaos. Okay? The pegostat won't allow them that freedom. Okay? Are they going to scream? Are they going to hate it? If they're younger, they are. This one's a little bit too old for the pegostat, to be honest with you. That looks like a 2.5-year-old. That's too big. Okay. 2.5-year-olds are big boys. They can stand by themselves on a little step stool, right? But the younger ones, they are gonna scream. Yeah, because you're taking away their freedom to wiggle, which is the first freedom. Okay. We want them to scream. What? You are a sadist. No. Listen, if they scream, then right after they're done screaming, they're going to fill their lungs with air so they can let me have it again. Okay? I am going to get a deep inspiration right after the child has emptied their lungs, because they're going to wail, and then when they're out of breath, they go beep. Okay, let's do the lateral. Yeah. Turn. And then just time it again. So, and you know what? When I use the pegostat, I won't say never, but I rarely have to repeat. All right. We have one of these somewhere in the building. I do not know if it's in the back of the classroom or if it's been brought back over to the department. Okay? But the octagonal immobilizer is an effective tool, mostly in the floral room is where it's best utilized. Because with an octagonal immobilizer, you can roll to obliques. Okay? Very effective for upper GIs and BEs. I hope you're not doing pediatric BEs. Oh my God. Okay? But very effective for GI, fluoro, and other fluoro cases when we do need to get the child into oblique views. And so if I see the octagonal immobilizer, I'll point it out to you. It's very limited in its applications, and typically we're doing alternates like CT and ultrasound rather than going straight to a fluoro study for most pediatric patients. Occasionally there's just, All right, so our class of patients newborn to 3 years, These are big boys and girls, okay? So they can start to help out, especially if we have a cooperative parent. They're going to follow the parent's lead, okay? Um, Sit them up if they're used to sitting, right? If they are less than 6 months old and they're not used to sitting, then lay them down, okay? Unless you're specifically told to get an upright. If you're not specifically told to get an upright and the child's usual posture is laying down, I thought we were supposed to make them comfortable. Lay them down. Okay, that's what they're used to. But if they're older, if they're closer to 3 years old, they're starting to get that independence. They can do things for themselves because these are big boys and girls, right? And so you just play into that. You're a big boy. You can do this, right? All you got to do is stand still. It's not, stand, face the board, and just hold still for me, okay? You can push their shoulders forward, right? And say, okay, just lean your shoulders into the board and just get a little reinforcing, and bang, they're in position, okay? Less emotionally mature, they are going to be looking for feedback from mom and dad. So, hip. All right, for congenital hip dysplasia, you're going to do bilateral pelvis. Oh, look, we give the kid a book. Okay, now I would suggest a comic book or something of that nature, or something, scale. I wouldn't suggest an X-ray curriculum textbook. Okay, not unless you want the child to scream. That was a joke. You like the joke? Okay. The diaper is going to produce artifact, even more so if the diaper is wet. Okay. It's got an absorbent polymer in the padding. That polymer expands and tethers water molecules to various points on the polymer chain. And so you basically get a fluid pocket in the diaper, and that attenuates the X-ray. It makes an artifact, okay? The polymer fiber is thick enough that even if it's dry, it does show up, okay? With the congenital hip dysplasia, you're going to do bilateral hips, so pelvis, with the toes in, and then you're going to do a second one frogged if they can. So knees out to the side, plantar surfaces of the feet pushed together. Okay. Skull radiography, we usually have sponges with handles on them. That's not exactly the head clamp. The head clamp is something that tethers to the table. I haven't seen a head clamp in about 10 years. What I have seen are circular sponges with hand grips on the backside. And so you grip the handles of the sponges and you basically sandwich the child's head and use the sponges to hold the child's head still in either an AP or a lateral. Okay. Typically when you're doing skull, you're just going to do AP lateral. Good enough. The lateral is actually more diagnostic than the AP. Okay. The bunny technique or the swaddling technique, I think that's described in the pediatric chapter. I don't recall if I kept the slide in there or not. But basically you just pin their arms in as you fold a triangular shaped sheet around them. I can show you with our little baby doll. If we have time on Monday, I'll show you guys how to do the mummification technique. Okay. Bone age is typically evaluation for dwarfism or growth defect, abnormal growth cycle, delayed growth cycle, things of that nature. Most of the time it's bilateral hands. After a certain age, I believe it's just the left wrist, maybe bilateral wrist. It varies according to protocol. The book has general guidance, but again, each individual facility, I think under 2 years of age, it's always bilateral hands, and then it varies after that according to facility. Foreign bodies, they're either going to order that some facilities have chest abdomen combined as an order, one view chest, one view abdomen. Some facilities will just order this as an KUB to include chest. Okay. You can ask your finance department as to how they want to charge those exams. They should have that sorted out by now, though. Okay. Regardless, we are going to get an extended, basically torsogram. We want to go from pubic symphysis all the way to the apex of the lungs. Okay. And we know that we're done with our radiography. We're done with our exam when we find the foreign body. Now this one is in the pylorus of the stomach, just about to go into the small bowel, but it looks a little big. So maybe it's going to get through the pyloric sphincter, maybe not. Okay. They might have to go back in and retrieve it with endoscope. So that's up to the doctor to determine. We don't determine that. Okay. If you do not see the coin or whatever it is the child swallowed, now if they didn't swallow anything metal, you might not see it. Okay. But if you know that it was a coin, or you think it was a coin and you don't see it, go back and do an AP neck. Okay. To include the mandible and to the bottom of the nose, the acanthion. Right. So the bottom of the nasal passages, to make sure you have all the mouth. Okay, it could be, the sneaky little devil could be hiding it under their tongue. Okay, or behind their back molar or whatever. Right, just to freak mom out. Right, it is a very good way to get out of school. Just saying. Okay, that's a little bit old for foreign body swallowing, but whatever. But you do want to go ahead and get a neck, even if you're not asked. Okay, just to make sure, because you don't want them coming back. They will come back for a neck X-ray, right? So just get it and include it, and make the radiologist just eat the charge and read it out. Okay, because we need to get on to the next thing. All right. Yes, it's terrible that the child swallowed something. Now, emergent, where you should send it and then take the patient back and immediately track down the emergency room physician, is if that thing's in the trachea or either of the bronchi. That's S-bar that emergency room physician and say, hey, you need to look at that now. Okay. But stomach, yeah, no big deal. It'll go where it needs to go. It's very rare that they'll go in after it. I mean, even a quarter can get through there. Okay, so they might give them some motility medicine, take 2 tablespoons of milk of magnesia until it passes, normal diet, whatever, and it just keeps the gut moving. So nothing too aggressive. No. Scoliosis. If you're evaluating scoliosis, it really should be upright. Protocol really should be AP or PA and lateral. Okay. Do shield if possible, but a lot of times the radiologist likes to see the entire pelvis, so might not be possible. We can, on adolescent females, shield the breast tissue as well. Okay. And try to collimate in. I know the spine is twisting side to side, so you're limited in that ability. But the less tissue you can expose, the better off you're going to be. Okay. This patient will have follow-up studies at least annually, maybe even every 6 months. So the less radiation you can apply, the better off the patient's going to be, because they are going to get increased dose to that of their peers because they have to have so many follow-up studies. So, hey, that's the end of the pediatric lecture. Okay. Let me pause for a drink of water and then we'll get into the geriatric lecture. All right. Oh, how did a cartoon of Mr. Shepherd get here? Anyway, geriatric radiography. Discuss physical, cognitive, psychosocial aspects of aging, physiology of aging by the body system, pathologies common in geriatric patients, patient care techniques for the geriatric population, accommodations for geriatric patients. I have the funny feeling that you guys have seen these already, but anyway, we'll just keep going. So geriatrics is the branch of medicine dealing with the aged and problems of aging, geriatric patients. So yes, I have to give it to him. Mr. Shepherd is not quite 65 years old. Not quite, right? But if you lean back and squint, it looks like a really tiny amount of time. Just saying. Okay. So gerontology is the study of the aged, folks in old age. Okay. Now, the aging process and the experience of our elderly patients is vastly affected by gender, race, ethnicity, social class, financial well-being. Okay. And there is we said ethnicity, but there's more than just your heritage, the genes that you inherited from your ancestors, but also how does your culture treat the elderly? And we do a terrible job as Americans. The Japanese embarrass the rest of the world with how well they treat their elderly. It's amazing. Okay. Ageism is discrimination against the elderly. Okay. Yeah. So telling jokes about Mr. Shepherd being old, yeah, I'm not in a position of power over him. So, yeah. But if I were to not deny him a job because he was old, that would be, yeah. Or if I were to underestimate his abilities because he was old. Okay, sometimes I do that. All right, sorry, Mr. Shepherd. Anyway, the quality of elderly care improves with appreciation for this population, positive attitudes of providers. Okay, so if we don't act jaded and we don't act annoyed or like they are a pain to deal with, then the patients respond better. Wait a minute, that's not just the aged, that's all of our patients. How about that? All right. Your elderly patients, though, a lot of them have fear and anxiety, but they also don't want to be a burden. Okay? So it's like they're having an internal struggle with themselves. So yeah. Okay. Common health complaints: weight gain, fatigue, loss of bone mass, joint stiffness, loneliness. Sight, hearing, taste, and smell also decline with age. Balance, coordination, strength, reaction time decrease with age. All right, provide one instruction at a time. Maybe speak more slowly. Okay. Get rid of background noise. If there's a fan running, can you shut it off? It's going to be easier for your patient to hear you with the fan turned off. Okay. Not all elderly patients are hard of hearing. Not all of them have cognitive delay. Okay. Not all of them have arthritis. Not all of them have excessive weight gain. Not all of them suffer from fatigue. Okay. These are common, but not guaranteed. Okay. Disease, aging, and disuse. Yes, do not disuse your brain. Use it appropriately. By that I mean play video games. Okay. Fears of cognitive loss, especially Alzheimer's disease, are widespread among older persons. It's going to be so amazing to see rates of Parkinson's and dementia and other Alzheimer's and those type of things just plummet when Generation X gets there. And they're all going to be scratching their, what's going on? What did we do? You gave us video games. That's what you did. And so we have We have rapid response time still. We have quick twitch muscles still. We have hand-eye coordination well beyond previous generations, and it doesn't decline. It maintains or it gets faster. Okay. My son is 22 years old, and I'm still better than him at some video games. I am never quitting. I'm going to be 80 years old, and I'm going to be whooping some 12-year-old's butt in Mario Kart. Or, no, I don't play Mario Kart. It'll be Battlefield. Okay. Cognitive loss, Alzheimer's disease, dementia. Alzheimer's is a specific type of dementia. Parkinson's is different. It's separate from dementia. They are not the same condition. Okay. Dementia is a progressive cognitive impairment that eventually interferes with daily function. And so your neural pathways that you're dependent upon, your short-term memory, but also remembering words and how to speak, and remembering activities, stuff that is just habits to you, like even remembering going to the bathroom or where the bathroom is, remembering how to brush your teeth, how to tie your shoes, all this kind of stuff slowly disappears, and it's a progression. It's a progression that it doesn't stop, but it just steadily keeps going until you need total care. Okay. Psychosocial effects. Okay, old people are lonely, and you probably figured that out first week of clinical education. Old people are extremely lonely. Okay, especially the ones that come from nursing homes, but also the ones that live alone. Okay. Loneliness does increase the probability of depression. Okay. And so I know we've got exam turnaround times, but these are human beings. You will make their day if you just spend 5 minutes to socialize with them. Ask them if they want anything. Ask them if they're being treated well, if there's anything that they could possibly need before you go. Okay? You'll make a world of difference if you just pause. You've got 5 minutes, trust me. I don't care what the manager says. I don't care what the department director says. You have 5 minutes to stop and check in and just treat them like a human being. Don't treat them like the next subject. Treat them like a real person. They'll appreciate it. Top 10 chronic conditions. I am happy to say that I have removed myself from a couple of these. So arthritis, yes, but it doesn't bother me as much anymore. Hypertension, apparently I'm still struggling with that one. I thought that one was fixed, but I just had an episode, so I will keep monitoring, right? May or may not keep you informed, but I'll keep monitoring. Hearing impairment, yeah, it's, especially when there's ambient noise. It's tricky for me to hear when there's like a fan running or something like that. The overhead projector drives me nuts. I can't, especially with some of you soft-spoken students. It's like it's all I can do to part of that's the autism. I can't, most people can tune out background noise. I can't. So that compounds my situation. So maybe not a loss of hearing. Maybe it's a little loss of hearing, but also autism. So heart disease, not yet. Cataracts, not yet. Deformity or orthopedic impairment. Well, I am a giant, but I take offense to that being called a deformity. Orthopedic impairment, because I'm a giant, I do lack a little bit of gross motor coordination. I can't run for crap. I'm just not aerodynamic. You know, those little 5 foot nothing Italian guys, man. And I'm not meaning to pick on the Italians. Any short male, the speed of those, they just zip. It's like, oh my God. And it's because they have a shorter stride, so they can take more steps per second. It doesn't take them as long to bring their leg forward. And my stride is longer, but that adversely affects my top speed, and my acceleration. Chronic sinusitis. This is one that I've eliminated because of my changes to diet. Yeah. So by cutting out high fructose corn syrup, seed oils, and most carbohydrates, my nasal passages are no longer chronically inflamed. It's fantastic. If I'd known this 10 years ago, I would have switched 10 years ago. I am breathing so much better than I used to. And I rarely get sinusitis anymore. So I still get a cold every now and then. Now, I say this, and then I'm going to get sinusitis by Thanksgiving, I'm sure. So, diabetes, not me. Visual impairment. Well, I mean, I wear glasses, so that's kind of been. I am having more trouble with the reading, so I might have to switch to bifocals soon. But don't tell Mr. Shepard. He'll just have a free-for-all with that. Varicose veins, unfortunately, I am genetically predisposed to those, although mine are milder than my father's were. So I'm happy about that. All right, nervous system disorders. Common causes of disability. So arteriosclerosis pays double. Not only is a risk for heart attack and stroke, but it affects the overall blood supply to the brain and to the spinal cord and the rest of the nervous system. And so it seems to affect the nervous system more than other systems. Okay, and so you're slowing reaction time, you're slowing cognitive processing time, and then eventually you get to infarctions, which are pockets of transient ischemia, or there's even minor pockets of total ischemia, and you start to lose brain cells. Okay. And that's what eventually leads to dementia. Okay. Musculoskeletal disorders, osteoporosis affects women more than men. Menopause is a terrible thing. Try to avoid it if you can, ladies. Okay. And the treatment for guarding against osteoporosis increases your risk for breast cancer. So the hormone replacement therapy. So damned if you do, damned if you don't. Really, I think I would still go with hormone replacement therapy. Keep my skeletal bones strong. So DJD and osteoarthritis, second most common cause of disability in the United States. Okay? And the total hip replacement, that is usually done to someone who the hip is about to fuse. That is, the joint space is completely eroded and degenerated, and there is no joint space, and now you're starting to see spurs from the pelvis and the acetabulum merge with the spurs from the femoral head. So that's when it's time to get the artificial hip. All right. Damage to the cardiovascular system, that would be your loss of elasticity of the arterial wall, plus the combination of deposition of arterial plaques, and the body's response to depositing fat and cholesterol on the inside of the lumen of the vessel is to spackle that over with a nice layer of calcium phosphate. Yes, your cholesterol plaques start to calcify. Okay. Yeah, it's the worst of all the physiologies. Like, this is exactly the worst thing that you could do to fix this. So it doesn't make any sense in the plan of, some adjustments are actually, changes to certain conditions. Some physiological changes are actually pretty effective, but this one is the worst. That squishy lump of like gelatinous goo, let's make that into a rock. Yeah, no, that's bad. It's so bad. Okay. So you do start to get circulation issue, postural hypotension, a greater probability that you're going to get orthostatic hypotension with poor circulation. You're also going to see neuropathy start to manifest in lower extremities and maybe even in the hands with circulation issues. The best way to avoid this is to avoid smoking tobacco products and to change your diet. Okay. Cardiovascular system disorders continued. So we talked about the blood vessels. The heart itself goes into something called congestive heart failure, which is a syndrome involving about 5 separate different conditions: cardiomegaly, pulmonary edema, emphysema. So congestive heart failure, that's COPD is emphysema, and pulmonary edema, bronchiectasis, pulmonary edema. Congestive heart failure is pulmonary edema and cardiomegaly. Okay. The heart grows in size but it's exactly backwards, to try to move more blood, but it actually gets less efficient at moving blood by getting bigger. Okay. The way that you control and prevent congestive heart failure is to control your diet, exercise, avoid smoking, and control your blood pressure, which I have to work on, apparently. Okay. Gastrointestinal disorders, all the fun stuff, right? So cheeseburgers, pizza, sugary drinks from Starbucks, yeah, all that stuff is just ruining your gut. It's also ruining your heart too. So don't smoke, don't drink a lot of alcohol. Looking at you, Nashville. High fiber, low sugar diet, low carbs, low processed foods. Okay, regular exercise, and the old. This should be on the cardiologist slide, or the cardiologist or cardiovascular system slides. If it tastes good, spit it out. That's what your cardiologist is going to say. Okay. Immune system decline. So our ability to respond promptly and aggressively declines as we age. And so we have a weaker immune system when we become elderly. Again, it's not universal. Some deteriorate faster than others, but there's an increased risk for diabetes, chronic conditions, pneumonia, nosocomial infections, tuberculosis, meningitis, urinary tract infections. Basically, all infections increase. Those are mentioned because those are the most common ones. Okay. Respiratory systems, your lungs will lose elasticity. Chronic bronchitis, emphysema, pneumonia, lung cancer. Okay. Now, emphysema and lung cancer, if you smoke, you increase the probability that you're getting those two. Moving on to the endocrine system, diabetes is the most common of the endocrine system disorders. It is, they're calling it insulin resistance now, where your body cells so insulin's job is to push glucose across the cell membrane. Okay. insulin resistance means that it takes more insulin to move the same amount of sugar, okay? And so something about your body cells are telling the insulin that, no, you can't shove more sugar into us, okay? And that's an insulin resistant condition. They figured this out in like the last 5 years or so. So they used to think it was an inability to produce insulin. Not necessarily the case. Now you do start tapering off your insulin production, but that's the effect. The cause is your body cells are becoming insulin resistant. So that's the new theory anyway. Regular exercise, weight loss, reduces risk, delays onset. So. Quick tips, rest times between projections. You have 15 seconds, okay? So if you're doing a unilateral, they're a 4, so they're a moderate risk, but you can stand them up for a short period of time. You're going to get the wheelchair right up to the bucky, okay? Get the cassette loaded, get the tube set up, guess where their height is, have them stand, get into position, do your final adjustment to height, and then run as fast as you can back to the control room while you're screaming breathing instructions. As soon as the exposure terminates, you run back into the room and let them sit down in the wheelchair. You have 15 seconds of strength. After 15 seconds, the patient's knees will buckle, but you have 15 seconds. Okay, so sit them down between positions. Okay, switch your cassette out, maybe change it from portrait to landscape or landscape to portrait, whatever. Okay, pull out the grab bar. Before they sit up, tell them that they're going to turn and put their left side against the board facing this other wall. Okay, turn the light on, tell them to stand up. They turn, get into position, twist them a little bit, get them square, right? And then run as fast as you can while you're screaming breathing instructions at them. Make the exposure and run back out as fast as you can and sit them down because you have 15 seconds. You'll see what I mean when you get there. Okay. Adhesive tape, our elderly patients might have tissue paper skin, okay, especially if they've been on steroids, okay, or they might bruise especially easily, okay. So avoid using adhesive tape. Paper tape is more gentle, but still I've seen that tear skin too. So use table pads, okay, don't skip the table pad for grandpa. Handrails if appropriate, okay. The patient will flail when you roll them up on their side. They just will, all right? Be ready for it. They'll flail, okay? Grab for their hand or their wrist, okay? Reassure them that they're not going to fall. You won't let them, okay? Put an ankle sponge on the far side of the table to kind of brace them so that it's kind of an uphill roll to get them to roll off the table away from you, because you really don't want to pick them up from that gap in between the wall and the table. That's tight quarters. That's a difficult lift. Okay. You don't want them falling off the table anyway. Just, you know. Use blankets, ankle sponges, other positioning aids. You got to try to get them comfortable. They're not going to be comfortable laying back flat on their back, but you have to try. Okay. Remember to bend their knees, put support under their knees. Okay. That kind of things. Let them keep their knees bent if you have to roll them onto their side. All right, joint commission. We'll revisit this again in QA/QC, but every healthcare professional has to be competent in performing exams across all age ranges. And for geriatric patients, they specifically want you to be able to cope with visual hearing impairments, digestive problems, that's more nursing and feeding, grief concerns, that's everybody, warmth and safety aids, that's everybody. Okay. Digestive and esophageal problems, that's more your patient care techs and your nurses because they have to feed them. Okay. So adaptation for PHS, let them bear hug the board. They don't have to put their back of their hands on their hips. Let them hold on to that thing. There are grab handles on most of them. Okay. Hyperkyphosis. You might find that someone who is hunchback and their chin is in the middle of their chest, you might find that you might want to sit them back into the wheelchair and do a steep, like a 30-degree angle, like shooting, just having the beam like skim over the top of their knees and extremely uphill into a cassette behind them. And that will kind of straighten them out a little bit. Okay, so angle into like the apex of the curve at the top of their T-spine. 30 might be a little steep. Okay. Pelvis hip fractures. Do not rotate the limb. Shoot it as it lies. Shoot across table, especially if the unaffected leg is fully mobile. Shoot across table. Do not frog a fractured hip. Upper extremity, contracture of limbs caused by stroke. So if a limb is paralyzed, it's going to atrophy and freeze in place. The joint space is going to seize up with arthritis, and the muscles are going to become guitar strings and bridge cable. If you try to straighten a contracted limb, you will tear the bicep. Don't do it. Okay? Never try to straighten out a contracted limb. Just shoot what you have. Okay? Lower extremity, you don't have to move them out of the wheelchair to the exam table. You can totally do foot and ankle examinations with a patient sitting in a wheelchair. So why transfer a patient if you don't have to? You don't. You never transfer. You never make an unnecessary transfer. Save your back. Save your patient from falling. Okay. Technical factors. Managing motion, both voluntary and involuntary. Yes, you're going to give them instructions, but they're uncomfortable, so they're going to shift. Okay? So you're going to have to go reposition. They sometimes shift right in the middle of the exposure, but if the exposure is fast enough, then they don't get the opportunity to move. We're going to learn in physics class in short order that the velocity equation is dependent upon the passage of time. Motion doesn't make sense without the passage of time. And so if we can capture an instant in time, a still photo, an exposure that's over with just as soon as it starts, less than 2/100ths of a second. That's nearly instantaneous. There's not a whole lot of opportunity for motion to take place in 2/100ths of a second. You might even capture the heart free of motion in between beats if you time it exactly right. Yeah, it'll look a little freaky to you. All right, but shorter exposure times, just aside from good patient instructions and a cooperative patient, shorter exposure times are just the most effective strategy at eliminating motion. All right, it's hell getting old. Don't get old if you can help it. Okay. Sorry I got this to you last minute. I'm going to go back and check. I can't remember if I shared this with you for part of general patient care skills or not. But if I did, it doesn't hurt for you to listen to it again. So, all right, take care, y'all.